So thank you, Olat. We are waiting for your presentation.
So, hello, good afternoon, everyone, and thank you for this invitation. I'm really happy to share this session with the other speakers. We've been working with Nan and Christoph before, and I'm very happy to be working in this new aim with them. I guess Cynthia just invited me to speak about the barriers or the difficulties of implementing PREMs in clinical practice because I have suffered the process in the last years and I'm still fighting with it. So I will share with you the experience we've been working. So let me start with this graph, which is for sure familiar for most of you. These are the intervention areas for action. For action, I would like to highlight this word, that the European Commission has presented through the Mission on Cancer. And we all know that we should prevent what is preventable, and we should optimize diagnosis and treatment. And we all know that the goals that are behind this mission on cancer, as Claudio was saying in the previous session, are a dream, but we have to go for them, or we should go for them. And then we have this third column, which says we should support quality of life. And this third column is here, probably due to the evidence that we have, that it's telling us that the implementation of patient-reported measures can improve the management of patients, can predict meaningful clinical outcomes, and also allows for shared decision-making. But, however, we have lately had the experience of asking patients, what do you think are the most important constructs of your quality of life? We've been working in different chronic conditions, but specifically with oncological patients in the U-OnCall project. And what they have told us is that maybe we're missing something. When they understand quality of life, they may include some constructs that we understand as experience and not as health outcomes or quality of life, as is been understood in the last decades. So we guess that probably this third column should incorporate PROMs and PREMs, so both patient-reported measures. And that will allow for increasing patient satisfaction with care, identify areas for service improvement, and also improve as health systems towards the value-based healthcare model we all have in mind. So, how do we implement PREMs into clinical practice, especially in oncology? So let's walk together through the 4 simple, very simple, but crucial steps or decisions that we should make before implementing PREMs in our unit, in our institution, in our region. First problem, which instrument should we administer? For sure, you, if you're clinicians, you may be familiar with PROMs. And you know we have generic PROMs in blue here, or you have other specific PROMs, specific models for your tumor location, even specific PROMs for other pathologies or for mental disorders that may go together with an oncological diagnosis, etc. So there are guidelines, many guidelines, that help clinicians and researchers to choose the most adequate PROM. You may all know ICHOM standard sets. ICHOM standard sets said, okay, many experts, after reviewing what we have made some recommendations. We should use the EPIC 26 questionnaire for prostate cancer, for example. Okay? That helps us in the selection of the instrument. But what happens with PREMs? You have here the PREMs, the most used one, the generic most used ones in red here. They came after, okay? So we are just behind PREMs. Or we can say we're working with them now. We are trying to develop these guidelines that Christoph just was speaking about. So what it's been done until now for selecting the most adequate PREM? So depending on your objective, you may be interested in some constructs that more interest than in others. So that may be an issue for selecting an instrument. Also the length, for example. Can you administer, I don't know, 50 items to every patient? Or it should be 15 as a maximum, okay? So, for example, talking about constructs, we have this mapping here. It was published in 2018. And you can see, for example, the PATHIC. The PATHIC is a quite used, frequently used PREM. It's the fifth starting from the left there. And you can see it has a brown area telling us that it gives considerable relevance to the empowerment of patients. Okay? Maybe you're interested in that, on measuring that on your patients, or measuring that in that moment in your service or unit, and it doesn't have to be the case forever, but now, yes. Or, on the other hand, you have on the right the PC, another generic instrument that it's quite used. This has a pinky area focus on the coordination within teams in the same institution. Because we, as patients, are not only attending our oncologist or I don't know, other specialists. We are just attending many, probably psychologists also. Okay, even nurses, the nurses that coordinate the units in the oncological teams. Okay, so this helps to choose the most adequate PREM. What happened in our institution was we presented these constructs and the items behind these constructs to several focus groups of patients, chronic patients, also including oncological patients in this case, and we ended up with a new PREM. Were those good news? Not really at the beginning, but we have understood there was a need for a PREM, a short PREM, a PREM that didn't focus in satisfaction, as Sabina just summed up, but in real problems that patients perceived as improvable, okay? And also there was scarce items especially focused on chronic patients. So they needed a continued care experience measure. And so we ended up with a new instrument. Probably the colleague that was just speaking before is developing a new PREM because they have identified a need, a gap there. And there are, I think that we'll see new PREMs coming in the following years. Another initiative to be able to choose the most adequate PREM was recently published. It was conducted by a clinician group in the Netherlands. They also took all the potential PREMs that could be applicable for the oncological population, and they also they added the information coming from focus groups of patients. They have ended up after mapping and prioritizations process and qualitative approaches, they have ended up with an item bank of experience items with 76 questions. Okay? This may end in a dynamic instrument, but we can skip this part and maybe discuss it if there's someone interested after. So, okay, imagine we have already selected the instrument, we have our instrument, but now we have to decide how are we going to administer this instrument, okay? So we are all, I think, agree in the fact that PREMs should be anonymous. I mean, we don't collect or we don't gather, or even worse, we don't save data, individual data, nominal data on PREMs, because we don't need it. I mean, it's different for PREMs. As Christoph just has shown us, we can use longitudinal individual PREMs data to know how well a patient has improved since the prostatectomy, for example. But it's not the case for PREMs. PREMs are usually used and should be used in an aggregated way. Moreover, it has ethical issues behind if you treat it as a nominal, because patients may be sensitive to the answer if they know that probably the patient, the doctor, the nurse is going to see the responses, and they're going to know it was me that I told that that specific doctor didn't explain the side effects correctly, or etc. So, and it's the law behind that also in some areas. So also regarding administration, we have another problem. Are we administering this with paper and pencil? Are we administering it by telephone interview? Or maybe we're receiving a link as a text message, as an email? Is our population especially prepared for one of these modes of administration? Can we combine these modes of administration? These are all the questions that we have in mind. And most importantly, behind these modes of administration and saving and gathering this data, there's a platform, okay? So for PREMs administration, this platform nowadays is a problem that it's usually solved. Why solved? Because in one hand, we have clinical trials. They are usually providing their own platform, so you gather all data, including PREMs information, okay? And the pharma company just has an agreement with your institution, and you have that platform working there. You cannot use that platform with individual information for PREMs, so we have to look for an alternative. Another way of gathering data and saving it in the PREMs case is the health system of your institution, the IT or the medical records that your institution has. We now, in Catalonia, we can, as clinicians, prescribe a PREM within the clinical record of each patient, and you can see the results when it answers. You can see the evolution of that PREMs scores, but it's not the case with the PREMs. Once again, we don't want the clinician to prescribe. They don't want to prescribe it, probably, or we as clinicians won't want to prescribe it. And we don't want them to see the answers of the patients. So maybe I have included RedCap here, because for us it's been a great solution, and maybe it could be the case for some of you also. Okay, we have the instrument, we have decided the way we are administering and gathering data and saving all this data, but as we've been discussing now, when are we administering this PREM? Okay, and with frequency. So I think we have to take into account that oncologic patients are special patients in this sense. And we don't want patient-reported measures to be a burden for our patients. So we have to really think and make a decision based on all the visits that an oncological patient may have in 1 month. Probably not in the same service or unit. So I probably want to gather the information on experience on all these different visits or units. But I have to think if the patient can just answer all this or wants to answer all this. That's why including patients in all these designs is so important, to make all these decisions. And finally, the last decision we should make before implementing PREMs is what are we gonna do with the results? Are we just gathering this information because it is in the law? Because we want to be certified and get an accreditation saying, hey, we are a patient-centered institution, we are following this new approach? Or are we really thinking on doing some interventions, at least at a very low level, a service level, unit level. In this sense, I will say that contrary to what Christophe just said, yes, I believe that we can do this and we can make some changes, even they are small changes, okay? Based on our experience, if you identify a problem, for example, we identify a problem, examples are always useful for explaining things. We identify a problem in a unit, and that was patients were reporting for six months that doctors talked in front of them as if they weren't there, as if the patient wasn't there. So they go into the room, they speak to each other, doctors, and the patient is like, wow. Okay, so we told this unit, you have these problems, we have seen it consistently several months, please do something. They were the first ones that wanted to change that. They weren't aware of that. And they have changed it, and they have improved it. So that are the mini improvements we can do. Another issue was medication after discharge and their related side effects. Okay, so patients were saying, at our institution, there was a problem with that. We were not explaining enough the side effects of medication that they were given after discharge. So we've made an action on that, and that's why PREMs can have an impact. Apart from these institutional low-level improvements, we should, as Sabine and Christophe has mentioned, we should make this data available. I really, really like what the Canadian Health Service has done with all the PREM data. They have made some aggregated analysis, stratifying by pathology, by providers, and they have it in the web tool that each patient has individually. And they also have public periodical reports with all this information, but moreover, they will give you access if you justify the reason why you want this access, so to be able to analyze this data under your requirements, criteria, etc. So that's important. So finally, if you manage to put all these pieces together, yes, the answer may be it is feasible to implement PROMs and PREMs. We have 3 experiences in our area in Barcelona. So we have a general population survey, kind of what Sabina just explained for the Italian region. It was developed 15 years ago, so it was satisfaction, and now we are working for it to be more based on experience, to be standardized, to be validated, and to be able not to only represent all the Catalan region, but also smaller areas. So we're working on that as a macro project. We also have an institutional strategic objective in Hospital del Mar in Barcelona. It's been working for more than 1 year in inpatients, and we will start hopefully next month for all outpatients, or with all outpatients, or if not with all, at least with the 10 selected and prioritized units. What is going on now is that just at discharge, each patient that has been hospitalized, it's given a note. The note says something like this: in a week, you may receive a text message with a survey link aimed to know your health status and how you value the care received during this hospitalization. If this is the case, we really appreciate your participation, etc. 7 days after this discharge, and I would like to highlight 7 days after. That was a criteria initially defined for all the hospital, but now the different services are like redesigning and saying, okay, in our case, it could be better if it's 24 hours after discharge. In our case, maybe 3 days after discharge. It will make more sense. But now we have 7 days for everyone. that week after the patient receives text message with a link, if he or she decided to participate, they have a survey and they have to ask the EQ5D5L as PROM and the PCARE patient experience questionnaire as PREM. I won't go on in details, but talking about barriers, I would like to highlight the first thing as patient you can do is change the language. Now it is possible in Catalan and Spanish, but we are working to have it in other languages because our hospital covers an area with a high percentage of migrants, and that language is being a barrier for the participation in a patient-reported objective, so it doesn't make many sense for us. And also it informs and remarks the patient that the experience information is going to be treated in an anonymous way. The third and last example I'm bringing here is a research project in which our institution is implementing PROMs and PREMs in these 5 units. It's breast cancer, prostate cancer, chronic kidney disease unit, heart failure, and bariatric surgery. This objective, or the objective of this research project was not the implementation per se, but the assessment of this implementation. I mean, we are kind of convinced that we should implement PROMs and PREMs, but can we really measure if this has an impact? It is a positive impact? I mean, are we just adding burden to both health professionals and patients? Or this is useful for something? And this is the aim of this research project. I'm happy to say that even we are far away from Nanes and her team, we have incorporated patients as co-researcher, and we are learning a lot from them here. And they have participated in the design, so when to administer each thing. Also in the development of the tool for the assessment, for assessing this impact. And also in the development of the PREM measure that we are administering here. So finally, as biologists by training, I would like to remark that biomarkers often fail to correspond with how a patient is actually feeling. But patient-reported measures may complement them by adding information on what actually matters to patients. Thank you.
Thank you very much, Ola. It's a very interesting presentation. Are there any questions about Ola's presentation? We are the last in the day. We are
I know.
Are there any questions? I have one question. May I ask? What's the response rate that you had on this?
30%.
30%.
Which
okay.
is not bad.
Which is not high, but it's not low.
No, it's not bad.
Yes,
30% is not bad.
Because recently I've heard about, so there was a survey and they said a 50% response rate. And somebody said, so low. No, so high.
So high, yeah.
Okay,
yeah.
So that's good. Thank you. Alan, again. Alan, sorry. We have Alan.
Thank you.
Okay. I didn't realize.
You mentioned that we would do this on the aggregated level. We don't want to have a patient-specific level data. But will we be able to see difference on the aggregated level over time? So let's say that if you do assessments now, then 6 months later, are we going to be able to see the difference on the aggregated level? How much time do we need between the testing to actually see the difference on the aggregated level? Say it's national level, or...
Okay, we've tried to measure that time within our institution, not a national, at regional level. And I will say, you first have to control for all the other variables. I mean, you have to make sure that this 30% that is answering has more or less the same profile. And PROMs are also helping for this. I mean, it's always people answering the PREM on high levels of PROMs, I mean, with a very high health status, or the contrary. So we're kind of monitoring this, and we are expecting we are kind of seeing some improvement after the intervention about these doctors talking without realizing they have a patient in front of them. And it looks like we have some improvement, but we cannot say that statistically significant yet. We'll have to wait, I think. And we're hoping not to lose the effect due to time, so that this keeps, kind of maintenance.
If I understand, you are saying that it's always important to link at least some basic level of PROM assessment. I mean,
We
something
have
like,
done it,
yes,
yeah.
or the Q5D or something
At
like.
least to see that your representativeness is always the same,
where you
like
are.
the characteristics of the patients, yeah.
Okay.
Yeah.